When you think about um, like a historic building surviving a massive catastrophic fire, the initial reaction is usually just pure relief.
Right, yeah. The structure is intact, so the immediate crisis is basically over.
Exactly. You stand on the street, you look up at the stone facade, and you think, it stands, we saved it.
Mm.
But imagine what you might find if you were to look inside the walls a year later. The intense thermal energy of that fire fundamentally altered the internal plumbing and the wiring.
Yeah, the invisible damage.
Right. So the pipes are slowly calcifying, the wires are, fusing together. And even though the building looks perfectly fine from the outside, the internal infrastructure is just quietly, inevitably shutting down.
Which is a terrifying thought, honestly.
It is. And that invisible delayed collapse
Yeah.
is exactly what we are investigating today for you in this deep dive. We're looking at the long-term realities of pelvic radiation for gynecological cancers.
And it's a highly specific, really fascinating biological puzzle that honestly often flies under the radar.
Yeah.
Because, just to ground us in the clinical reality here, the incidence of gynecological tumors, cervical, endometrial, ovarian, it remains incredibly high.
Like staggering numbers, right?
Yeah, we saw roughly 290,000 new cases in China in 2022 alone. And because these are so frequently diagnosed at an advanced stage, the standard curative strategy just has to be aggressive.
It's a marvel of modern medicine. I mean, it literally saves lives. But our mission today is that we really need to unpack what exactly happens to the tiny microscopic blood vessels in the pelvis, months or even years after that radiation stops.
Right, the aftermath.
Because the treatment protocols we're looking at, they combine external beam radiotherapy with intercavitary brachytherapy, which is where specialized radioactive isotopes are placed directly inside the vaginal canal.
And the doses are massive. The apex of the vagina can tolerate up to 140 gray of radiation.
Which is just a staggering amount of kinetic energy.
It really is.
Just to understand the physics of it for a second, that 140 gray is generating massive ionization. It's physically stripping electrons from the biological water within the tissue.
Yeah, it creates this storm of reactive oxygen species.
Exactly. And those shear the DNA of the tumor cells. And rapidly dividing cancer cells, they can't repair those double-strand breaks, so they undergo apoptosis, they die off, which is, exactly what we want to happen.
Precisely. I mean, it is entirely necessary to cure the cancer, but returning to your building metaphor,
Right.
the fire is put out, but the walls absorbed an immense amount of heat. The tolerance of the surrounding healthy perivaginal tissue is significantly lower than that 140 gray.
So it takes a hit.
A massive hit. And what we're focusing on today is how that radiation fundamentally alters the microvascular architecture, like the tiny plumbing of the tissue, and how that leads to this cascade of severe downstream effects.
Specifically, we're zeroing in on the complete loss of transudate moisture.
Yeah.
Right.
Yes. So let's trace this microscopic domino effect. Because the initial thought might be that, well, radiation simply burns the tissue, and a burn heals and leaves a scar.
Which makes intuitive sense.
It does, but the clinical data shows us this isn't just a localized static burn. It's a progressive compounding failure.
Wow. Okay, so where does it start?
The initial insult from the ionizing radiation doesn't just eradicate the cancer cells, it profoundly damages the endothelium, which is the inner lining of the local capillary beds and arterioles.
Now, I want to pause here for a second because I had a question about this.
Sure.
If radiation is designed to target rapidly dividing cells, why are these normal, totally stable endothelial cells taking such a massive long-term hit? I mean, they aren't turning over at the rate of a tumor, are they?
No, they aren't, and that is the crucial distinction here. Because they aren't rapidly dividing, they don't immediately undergo apoptosis.
Oh, so they don't die right away.
Exactly. Instead, the radiation induces a state of cellular senescence. The endothelial cells survive the initial hit, but their functional DNA is damaged.
So they're just lingering.
Yeah, they become these dysfunctional pro-inflammatory zombies, essentially. And this triggers a chronic condition called progressive endarteritis.
Progressive endarteritis. Okay, so we have this persistent, localized inflammation of the inner lining of these small arteries.
Right.
And because it's progressive, it just doesn't resolve. So over months or years, this constant inflammatory signaling causes the walls of these tiny blood vessels to swell, and they proliferate abnormally and thicken until they literally obliterate their own lumens, like they close up completely.
Exactly. It's an obliterative
It's like,
process.
okay, it sounds like we're trying to weed a garden, right?
Right.
And we use a really heavy tiller to get the deep, stubborn roots of the weeds out.
Okay, I like this.
But in the process, we accidentally crush the underground sprinkler system. And we don't even realize we've done it until the next season rolls around, and suddenly the grass is dying off because there's absolutely no water reaching the surface.
That analogy maps perfectly onto the biology here. You've crushed the sprinkler system, and the immediate physiological consequence of that endarteritis is severe cellular hypoxia.
Because the pipes are crushed.
Right. Because those small supplying arteries are obliterated, the blood supply is choked off, the perivaginal tissue is literally starved of oxygen. And this brings us directly to the core issue of transudate moisture.
This is such a fascinating mechanism for you listening, because when most of us think of biological moisture or, lubrication, we immediately think of glandular secretion.
Like sweat or tears.
Exactly. We picture sweat glands or salivary glands acting like little individual faucets turning on. But vaginal lubrication doesn't primarily come from glands at all. It is a transudate.
Yes, it is an ultrafiltrate of the blood plasma itself.
Wait, so it's literally filtered blood?
Essentially, yes. Transudate moisture relies entirely on a rich, healthy, highly pressurized capillary bed. So your intact sprinkler system.
So how does that physical transfer actually happen? Like, how does the fluid get out?
It's all about hydrostatic pressure. The blood vessels in the healthy vaginal submucosa are so abundant that the physical pressure of the blood flowing through them forces fluid out of the capillaries.
Oh, it just squeezes it out.
Yeah, it pushes it through the interstitial space and straight through the vaginal epithelium to create moisture on the surface.
It's kind of like a damp sponge where the moisture is coming from deep within a pressurized vascular network pushing outward.
Exactly.
But if progressive endarteritis has obliterated those tiny arteries?
Then the intravascular hydrostatic pressure drops to near zero.
Wow.
The blood flow stops. And without that pressurized blood supply, the physical mechanism for transudate filtration is completely broken.
The tissue simply cannot produce moisture.
It can't. But that loss of lubrication is really just the first clinical symptom, because now you have a structural matrix that is completely deprived of oxygen.
Right, because if a building loses its plumbing, the physical walls just sit there, they remain static. But biology is dynamic. The perivaginal tissue actually starts to actively remodel itself in response to this hypoxic environment.
It does, and it remodels itself in a highly pathological way.
How so?
Well, in a state of chronic hypoxia, the fibroblasts, which are the specialized cells responsible for synthesizing the extracellular matrix and collagen, they become highly dysfunctional.
It's like they panic. They are operating in a low-oxygen, high-stress environment, and instead of carefully weaving fine, flexible connective tissue, they just start pouring concrete.
That's a highly accurate way to visualize it, honestly. Healthy perivaginal tissue requires a very specific ratio of type 1 to type 3 collagen to maintain its compliance and stretch.
Right.
But the clinical biopsies from irradiated tissue show that these hypoxic fibroblasts wildly overproduce dense, highly cross-linked collagen.
Which is basically scar tissue.
Yes, it creates severe fibrosis. We are talking about rigid, heavy scarring replacing what used to be functional mucosa.
And the clinical data on this is striking. Mucosal atrophy, where the tissue physically shrinks and thins out due to the lack of blood, was observed in 91% of survivors in these studies.
It's incredibly prevalent.
And profound pelvic fibrosis was seen in 97%.
Yeah, it's a near-universal downstream consequence of the vascular collapse.
But okay, while the collagen response makes intuitive sense to me, scar tissue forming after trauma, there is a specific morphological study in the data that completely threw me.
Oh, the elastin study.
Yes. It's this total anomaly regarding a structural protein called elastin.
Right. The study comparing the biopsies of 34 cervical cancer survivors against 37 age-matched healthy controls.
Yeah. So they ran a deep microscopic analysis of the vaginal wall biopsies, and they found that in the cancer survivors who had undergone radiation, the area fraction of elastin actually increased dramatically.
Quite a bit, yeah.
It went up to 10.0% compared to just 3.4% of the healthy controls.
So nearly 3 times as much.
3 times as much elastin. Now, I'm looking at this and thinking, elastin is the exact protein responsible for elasticity.
It's in the name.
Right. It's in our skin, it's in our lungs, it's what allows blood vessels to pulse. If these patients are producing triple the amount of elastin, why does the clinical data concurrently state that Up to 88% of these patients suffer from severe vaginal stenosis.
Which is where the canal becomes incredibly stiff and narrowed.
Yeah, it loses all its elasticity. How does a tissue with triple the elastin become entirely rigid?
It seems completely contradictory, right?
Really?
Until you look at the architecture of the protein rather than just the raw volume, it comes down to a pathological condition called elastosis.
Elastosis, okay.
Yeah, the body isn't producing normal functional elastin fibers anymore. In the healthy control biopsies, the elastin forms this beautifully organized, thin, flexible subepithelial layer.
Like a nice, neat mesh.
Exactly. It relies on a microfibril scaffold, primarily made of a protein called fibrillin, to align properly. It acts like a finely woven mesh that allows the tissue to distend and instantly snap back into place.
So what happens to that scaffolding in the irradiated tissue?
It's gone. The hypoxic damaged fibroblasts are still synthesizing elastin precursors, sure,
Yeah.
but the organizational scaffolding is destroyed.
Oh, so there's no blueprint for it to follow.
Right. And without it, the elastin doesn't weave into a mesh at all. The survivors' biopsies showed profound elastosis, where the elastin aggregates into thick, chaotic, amorphous clumps that are just irregularly scattered throughout the connective tissue.
Okay, so instead of a flexible, carefully woven rubber band, you're getting dense, chaotic balls of hardened glue interspersed through the tissue.
Exactly. It's the difference between a trampoline and a solid rubber tire.
Wow.
The material might fundamentally be similar, but the microscopic structure completely dictates the mechanical function. Because this elastin is thick, clumped, and highly disorganized, it actually restricts movement.
It acts as an anchor rather than a spring.
Precisely. And this architectural collapse translates to severe anatomical changes.
I can imagine.
Yeah, that same morphological study measured an average vaginal length of 7.0 centimeters in the survivors compared to 10.3 centimeters in the controls.
That's a significant shortening.
It physically shortens, entirely loses its compliance, and when you combine that stiff, fibrotic collagen matrix with the obliterated capillary beds,
You end up with a tissue that is completely dry, incredibly rigid, and highly fragile.
which brings us into the macroscopic lived reality for the patient. This isn't just an interesting finding to look at under an electron microscope. This manifests as late radiation tissue injury, or LRTI.
Right. And the insidious thing about LRTI is that it can present months or even years after the patient was given the all clear and told they were cancer-free.
Yes. Because irradiated tissues become increasingly atrophic over time as that endarteritis progresses, they completely lose their normal healing capacity.
So the symptoms are profound.
They severely impact quality of life. Patients experience severe dyspareunia, painful intercourse persistent dryness, and a very high risk of developing radionecrotic non-healing ulcers.
Radionecrotic meaning the local tissue is literally dying off from the delayed radiation damage.
Exactly.
And because we've crushed that vascular sprinkler system, the body can't even mount a normal immune response, right?
No, it can't.
There's no blood flow to deliver white blood cells or oxygen or the necessary nutrients to granulate and heal the ulcer.
It's a stagnant, dying environment. And in severe presentations of LRTI, those non-healing ulcers can erode deeply enough to perforate, leading to fistulas.
Which is an abnormal anatomical tunnel that forms between two hollow organ spaces.
Yeah. So years after a successful radiotherapy protocol, a patient could develop a vesicovaginal fistula, which is an opening between the bladder and the vaginal canal, or a rectovaginal fistula.
That is just a devastating secondary trauma to face
Yeah.
after successfully surviving a complex gynecological cancer.
That's incredibly difficult.
And as we look at the systemic picture, this localized vascular death is almost always compounded by iatrogenic menopause.
Yes, the pelvic radiation or the concurrent chemotherapy protocols permanently destroy ovarian function in a large percentage of these patients.
So not only has the local perivaginal tissue been structurally ruined and starved of blood, but the patient's entire systemic circulation is suddenly deprived of estrogen.
Right, and estrogen is critical for maintaining mucosal thickness, promoting blood flow, and keeping glycogen levels up in those tissues.
So it's a perfect storm of tissue degradation. The local plumbing is destroyed right as the systemic hormones that maintain the tissue are shut off.
Which presents an immense clinical challenge. I mean, how do we practically rehabilitate tissue that is locked in a hypoxic state, choked by dense type I collagen, anchored by chaotic elastosis, and cut off from systemic hormonal support?
It sounds physiologically impossible, honestly. Like once a capillary bed is obliterated, you can't just surgically wire in microscopic new ones.
You can't.
But the clinical interventions outline a really aggressive, multidisciplinary approach.
Yeah.
They attack this architectural collapse from 3 distinct angles: mechanical, topical, and systemic. So let's break these down, starting with the mechanical.
Okay, so the mechanical intervention is primarily centered on vaginal dilation therapy. And it's important to note the clinical guidelines here are rigorous.
It's not a casual thing.
Not at all. This requires continuous oversight from oncology specialist nurses because the protocol is intense.
The standard recommendation is that patients need to use graduated vaginal dilators 3 times a week for at least a year, usually starting just 2 to 4 weeks after the radiotherapy concludes.
Yes. And the mechanism behind this isn't just passive stretching, it's active mechanotransduction.
Mechanotransduction, so converting physical force into chemical activity.
Exactly. You are applying physical shear stress to the fibrotic tissue.
Right, because if you don't mechanically force the tissue to distend, the chaotic collagen fibers will simply cross-link across the collapsed walls.
Without mechanical intervention, the opposing walls of mucosa can literally fuse together, creating dense adhesions known as synechia.
Oh.
By applying physical stretch, you are sending mechanical signals to the fibroblasts to align the new collagen fibers longitudinally rather than haphazardly.
So it trains the collagen.
Yes, maintaining the patency and the length of the canal.
So you are mechanically preventing the architecture from collapsing inward and fusing. But you still have the issue of extreme dryness and atrophy. That's where the topical interventions come in. The protocols utilize hyaluronic acid, vitamin E, and low-dose localized vaginal estrogens.
These topicals are doing a whole lot of heavy lifting on the mucosal surface. Hyaluronic acid is brilliant here because it is a highly hydrophilic molecule. It binds and retains massive amounts of water,
which provides exogenous moisture to a tissue that can no longer produce its own transudate ultrafiltrate.
Exactly. And the vitamin E acts as a potent local antioxidant to mitigate the ongoing radical damage.
And what about the localized low-dose estrogen? Because since the systemic estrogen is gone due to the iatrogenic menopause, applying it directly to the tissue bypasses the systemic circulation entirely, right?
Correct. It binds directly to the estrogen receptors that are still present in the basal layer of the epithelium.
Okay.
It stimulates whatever localized cellular proliferation is still possible, thickens the mucosal layer, and slightly decreases the inflammatory profile of the tissue.
That makes sense.
Yeah.
But as effective as the dilators and the topical creams are, they are essentially symptom management, aren't they?
In a way, yes.
Like you are physically stretching the concrete and applying water to a dry surface, but the underground sprinkler system is still dead. The endarteritis is still there.
That's the real barrier.
This is where the third systemic intervention comes into play, and the mechanics of it are absolutely fascinating. We're talking about hyperbaric oxygen therapy, or HBOT.
Yeah, HBOT is the only intervention that actually attempts to reverse the root cause of the microvascular disaster.
Let's walk through the physics of how this actually alters the tissue. The clinical protocol involves placing the patient in a hyperbaric chamber and having them breathe 100% pure oxygen.
But crucially, it is pressurized to 2.5 atmospheres.
Okay, 2.5. And they undergo this for 60 to 120 minutes per session, often requiring 30 to 60 total sessions.
It's a huge time commitment.
It is.
Yeah.
Now, going back to our mechanisms, if the original biological failure is that the tiny arteries were obliterated by endarteritis, how does breathing oxygen fix the pipes? I mean, if a house has broken plumbing, pumping it full of highly pressurized water doesn't spontaneously generate new copper pipes.
No, it doesn't in a house, but human biology has regenerative pathways we can exploit. The key to HBOT lies in Henry's law of gas solubility.
Henry's law. Let's dig into that.
So, under normal atmospheric pressure, the oxygen in your blood is almost entirely carried by hemoglobin in the red blood cells.
Right.
And your hemoglobin is already about 97% saturated, just breathing room air. You cannot physically pack more oxygen onto the red blood cells.
They're completely full. And even if they weren't, if the capillary is obliterated, the red blood cell can't get into the tissue anyway. It's a traffic jam.
Precisely. It's blocked. But Henry's law dictates that if you increase the ambient pressure, like going to 2.5 atmospheres in the chamber, you physically force the oxygen gas to dissolve directly into the blood plasma itself.
The plasma.
Yeah.
So the liquid part of the blood.
Yes. You completely bypass the need for red blood cell
Oh,
delivery.
wow.
At 2.5 atmospheres, the oxygen concentration dissolved in the plasma increases by a factor of 10 to 15.
That is a massive spike.
It is. This super-oxygenated plasma is pushed deep into the vascular network. And because the concentration gradient is so incredibly high, the oxygen diffuses much further through the interstitial fluid than it normally could.
So it's penetrating deeply into those hypoxic, starving paravaginal tissues.
Exactly.
So you are delivering life-saving oxygen without needing fully intact arterial roads. It's like airdropping supplies over the traffic jam.
I love that. Airdropping supplies, exactly.
But how does that temporary influx of oxygen translate into a long-term structural fix for the blood vessels? Like the oxygen gets there, but the pipe is still broken?
Well, because in this context, oxygen isn't just acting as fuel for cellular metabolism, it acts as a profound epigenetic signaling molecule.
Okay.
That massive, repeated influx of hyperbaric oxygen addresses the microvascular architecture by upregulating the transcription of highly specific growth factors in the tissue.
Which ones?
Chiefly, vascular endothelial growth factor, or VEGF, and transforming growth factor beta 1.
Wait, VEGF, that's the master regulator for blood vessel growth, right?
It is. When VEGF and TGF-beta 1 are upregulated in the paravaginal tissue, it forcefully stimulates angiogenesis.
So it is.
Angiogenesis is the actual literal sprouting and growth of brand new capillaries from the existing undamaged vessels further upstream.
That is incredible.
Furthermore, it stimulates the mobilization and differentiation of vasculogenic stem cells from the bone marrow, directing them to the site of the radiation injury.
So by manipulating atmospheric pressure and gas solubility, you are literally forcing the tissue to build entirely new pipes. You are regenerating the sprinkler system.
You are. It allows the deep tissue to breathe again. It improves the extracellular matrix quality. It promotes the rapid healing of those stubborn, dangerous radionecrotic ulcers.
Right.
And crucially, by restoring a pressurized, functional capillary bed, it has the potential to restore the natural hydrostatic pressure gradient required for transudate moisture.
So you are directly counteracting the progressive endarteritis by growing a de novo microvascular network.
Exactly.
The physiological resilience of the body is truly astounding when we give it the right biochemical signals.
It really is.
So just to synthesize this entire architectural journey for you listening, pelvic radiation remains a vital, non-negotiable tool for eradicating gynecological cancers, but it leaves a hidden microscopic disaster in its wake, long after the tumor is gone.
Yes, the radiation induces cellular senescence in the endothelium. That triggers the progressive endarteritis that slowly obliterates the small supplying arteries, which entirely cuts off the blood pressure required to filter transudate moisture.
And that resulting hypoxia panics the local fibroblasts, causing a massive overproduction of dense, stiff type I collagen. It disrupts the fibrillin scaffolding, creating elastosis, those chaotic hardening clumps of elastin fibers that rob the tissue of its compliance and shorten the vaginal canal.
Right.
But through a rigorous combination of mechanical mechanotransduction with dilators, targeted topical hormones and antioxidants, and the profound physics of hyperbaric oxygen therapy, medical science is actually finding ways to force the body to physically rebuild that microscopic infrastructure.
Which leaves us with a truly provocative concept as we look toward the future of oncology.
What's that?
Well, if we now fully understand that late radiation tissue injury is fundamentally a progressive disease of the microblood vessels starving the tissue over a period of years,
Yeah.
could the future of cancer treatment involve administering specific vascular protector drugs concurrently during the radiation protocol itself?
Oh, like a prophylactic approach to the vascular damage.
Exactly. Imagine a clinical world where we can deliver that curative 140 gray to eradicate the tumor, but we simultaneously administer a targeted therapy that biologically shields the paravaginal endothelium from senescence.
Wow.
We cure the cancer, but we prevent the endarteritis from ever initiating, ensuring we never turn off the body's microscopic plumbing in the first place.
We let the building withstand the fire, but we make the pipes completely heat-proof.
Precisely.
That is a brilliant and really hopeful thought to mull over. For everyone listening, I hope this deep dive gave you a new appreciation for the staggering complexity of the microscopic whys behind our medical treatments. The body is an endlessly adaptable architecture, and sometimes the most critical biological battles are being fought in the smallest unseen vessels. Keep questioning the unseen mechanics of the world around you, and we'll catch you on the next one.